Next will be Dr. Kritaya. Dr. Kritaya is the Chief of Vascular Surgery at Chulalongkorn Hospital. King Chulalongkorn Memorial Hospital is one of the largest medical school in Thailand. It's in the central of Bangkok, and big service there and good experience of the endovascular procedure in that hospital. And Dr. Kritaya will share with us. Dr. Kritaya spent some time in Cleveland Clinic and in Stanford. And then came back and work here. Dr. Kritaya will share with us the AUI. This is one of the issues that we will still concern a bit about using AUI in our patients. So we'll learn from Dr. Kritaya. Dr. Kritaya, please.
Thank you, Dr. Bunpasit, and thank you, Medtronic, for organizing this nice meeting. I'll keep it short because the time is kind of late now. Okay, so I have a privilege to work with many colleagues at my hospital, a vascular team, cardiothoracic team, and radial intervention. We work together smoothly, no fighting at all. So I'm going to share a case. In my opinion, I don't like aortoiliac procedure. It's a kind of not physiologic. And even in ruptures, if you can cannulate the contralateral limb, I'll do a standard EVA. I won't convert to an AUI. But sometimes it's necessary to do an AUI. Like this case that I'm going to present is a 85-year-old Thai female patient, known aneurysm for many years, but lost follow-up. She came to the emergency department outside hospital with syncope and a pulsed high mass, did a CT scan, and found that she had a ruptured aneurysm. Okay, let's see if the video will play. Okay. I'll let it go. So the patient has an occlusion of the right external iliac artery and a ruptured aneurysm. Usually, if the patient is symptomatic, we could try to revascularize the iliac limb. But in the rupture case and the patient's syncope, you can see the contrast extravasation from the aneurysm. There's no time for revascularizing or recannulating the external iliac, so we decided to do aortounic iliac procedure for this patient. Okay, you can see the right external iliac artery is occluded. Okay, and the neck is 24 millimeters. The neck length is about 27 millimeters, so it's suitable for doing an endovascular aneurysm repair. So what would you do? Some people would choose to do an open repair. Some people would choose to do a AUI. So we chose to do an AUI, putting in a 28 device up, an extension limb. We put in a balloon from the brachial artery to occlude the aorta because the patient's vital sign isn't stable. Did an aortogram. And we tried to select the contralateral limb to occlude the right common iliac artery. Okay, selecting the right common iliac artery and putting in an occluder right there. After that, we put up the main device up the left groin, aiming for the lowest renal artery. Okay, and checking that we're not covering anything. Okay. After deploying the device, we touched the balloon at the neck and the overlapping parts to make sure there's no endoleak. And this is the final completion angiogram. You can see there's no endoleak there. The patient vital sign was stable, transferred to the ICU. 1 week after the AUI FemFem crossover, we did a CT scan. And you know the story, what's going to happen. Let's see, it's not running. Sorry about that. Okay. There's a type 1A endoleak now. So the stent has dropped down about 5 millimeters. So now we have a problem. The patient is post AUI, now has a type 1A endoleak with a ruptured aneurysm previously. And the patient was an 85-year-old female patient. So what should we do now? Open the patient and do a banding, or extend the ceiling zone?
But now we ask Ajahn Vira, what will you
Okay.
do? Will you do the banding, or will you do the extension, or will you do the endo anchor if you have it available?
Chimney.
Yeah.
Now I begin to try the PMEX to the both renal artery.
Oh, okay.
And
Okay.
aortic cup
That will be
extension.
another option. Okay.
Anybody else has any opinion what to do?
We will keep PMAC for to be the last resort.
Next.
I will not encourage people doing PMAC because this will be in the expert hand, I guess, because there will be a lot of uncontrolled environment for the PMACs, I would say. So if we started to do the PMAC, there will be a few problems, I guess. So let's talk about the more standard option.
Another option is a chimney, two chimney even.
Okay. So what we did was we decided to do a C-bar. Put in a B graft on the right renal 6 millimeters and the left renal 5 millimeters. This is, okay, so, there you go. You see we're trying to, Dr. Natisakan came and helped us, and Dr. Apinan selecting the left and right renal arteries. You see we could get a cannulation right there. The left renal artery, the right renal artery. And then balloon and deploy, extend the extension cuff and ballooning, touching up everything. And this is the completion angiogram, aortogram of the case. You can see all the visceral vessels are patent and the fem-fem crossover is still functional. Did a CT scan, again, 1 week after the procedure, you can see now that everything looks fine. The patients did well for a couple of weeks, and then she had an intracerebral hemorrhage and unfortunately passed away, unrelated with the aneurysm. Okay. Thank you very much.
Thank you very much. Any comments? Any questions?
I have one question. At the first operation, the patient present with rupture and right iliac artery occlusion.
Yes.
If the patient have any symptom before for the iliac occlusion?
No, the patient lost follow-up.
Yeah, but in the rupture condition, I think only AUI without fem bypass is enough because the patient no any symptom of the iliac occlusion.
Yeah.
I think.
Okay.
That went through our mind too, but since everything was over there and the patient was stable, we decided to do a fem-fem crossover.
Yeah. If we can do fem crossover, if patient survive the operation,
Right.
we'll go home with a happy leg,
Right.
another happy leg. So maybe help. But yeah, Dr. Vira point is important too, that this is another option. We can leave it alone, or we can add a fem crossover. Any questions and comments? Dr. Kwang, do you see more often about one limb occlusion? I mean, patient come in with aneurysm with one iliac occluded, and then have only one, because there are some people mentioned that not ruptured, elective case. Maybe can we try to cannulate that occluded limb, so we can convert from occluded one iliac into a bifurcated graft, and so maybe better to do that way. I'm not sure. What do you think? Ask the panel, Dr. Kwang, Dr. Vira. You have that.
Like the
Any-
patient came in with a claudication on the left leg and work up, found
Right.
an aneurysm.
Right,
What
right.
would you do?
Yeah.
Depend on the symptom. If the patient have no any symptom with already occluded iliac artery, I just do only AUI and without. I don't do the
Even no bypass, no fem
Yeah, yeah.
crossover.
Yeah.
Okay. Okay.
Yeah, I think so because if the patient already naturally healing or got some collateral good enough for the patient and without
Right.
the symptom,
Right.
I don't think that we make the procedure more complex.
I see.
So this is our thinking.
Okay.
So try to keep everything is simple, as simple as possible.
Yeah. Yeah. Add more procedure. Add potential complications.
Yeah.
At PP. Okay. Yes.
I think it depends on the status of the internal iliac arteries. In the aortounifemoral, where you are crossing, are you crossing the internal iliac arteries? What is the condition of the opposite internal iliac arteries? If doing a bypass, crossover bypass will preserve the internal iliac arteries, I think we should do it, even if the common iliac artery is occluded.
That's an important
Yeah.
issue too.
Yeah. Okay. Yeah. That depends on the level of the occlusion that you mentioned. Yeah. Thank you. Okay. Well, thank you very much, Dr. Kritaya, for a nice case. Thank you.